Thank you guys so much for coming. Thank you for inviting me, town of Quincy. I am Dr. Monique Nugent. I am a hospitalist at South Shore Hospital, which is your local hospital here on the South Shore. I also do some telemedicine, more aimed around patient advocacy work. I write about hospitals and hospital stays. I have a podcast about hospitals and hospital stays because I am kind of really obsessed with making sure we improve the experience and the outcomes of hospitals and hospital stays for patients and their loved ones through a hospitalization. And that conversation has to be a two-way conversation. We as physicians have to focus on how we improve, but also we have to bring the community into the conversation so the community, when they come into the hospital, understand what's happening and how they can advocate for themselves. So today's presentation is called A Guide for Hospitalization. And what I'm going to do is kind of walk you through what you can expect through an average hospital stay and how you can leverage each step so that you are advocating for yourself or your loved one who's hospitalized to be able to get the things that you need, maintain safety, quality, and then do the most important thing, and that's be set up for success for discharge. Because you want to leave the hospital. The things that go on in the hospital all go on with the goal of leaving the hospital. So how do we leave successfully so we don't have to come back? So I just want to tell you guys a little bit about myself before we get started. When I started the conversation, I said, I'm a hospitalist. What is that? I'm a board certified internist. So I take care of adults and adults only. I don't see children. I don't see pregnant women. But I have chosen to formalize my practice in the hospital space. So you could not make an appointment to see me. The only way you see me is if you come into the emergency department and they say, oh, you need to stay. Or if your doctor sends you to the hospital to be admitted, you will be cared for by someone like myself, a hospitalist. Hospital medicine is the specialty that I practice. Hospital medicine is the care of patients during this really unique time in their healthcare journey, which is a 4 to 5 day hospital stay. So if you think back a while ago, the way doctors used to practice was they would go to their clinic, they would see their patients, they'd run over to the hospital, they'd do a couple things, they'd run back to their clinic, maybe call the nurse, trying to care for patients in both places. Sometime in the 90s, a group of enterprising young physicians realized that the work that was going on in the hospital was a lot more specialized and needed more eyes there and people who could be there. So they started going around and saying to the docs, let's cut a bit of a financial agreement here. I will see your patients in the hospital and only in the hospital, and you will see patients in the clinic and only in the clinic. And this way we both benefit, but the patients benefit also from having us. And that was the birth of hospital medicine, the specialty. We're one of the youngest specialties, right? Everyone knows cardiologists, everyone knows your nephrologist, but your hospitalist, someone who knows how to care for patients in an acute care setting, it's a pretty young specialty. So what does that do for a hospital and for hospitalized patients? Number one, that means somebody is always there, right? Me or my colleagues are always present. There is a physician always available in the hospital 24/7. At night, we kind of specialize them down even more. We call them nocturnists because the work that goes on in a hospital at night is very different than the work that goes on in a hospital in the daytime, right? But it also means that hospitals have access to physicians so we can address emergencies in a more timely fashion, avoid emergencies, hopefully. We're faster at admission and discharge. So hospitals that are supported by dedicated physicians, by hospitalists, have that benefit of a group of physicians who know how to work in the system, support the system, and have built their career. We are now, like I said, a specialty. There's lots of research. We've got our own organization. We've got magazines, because we've come to understand that caring for you while you are acutely ill is very different than caring for you if you are able to go home and back and forth from the clinic. So how did I become a hospitalist? Well, when you are a resident, you have to choose if you're going to specialize or not. And so I chose to go into a non-clinical specialty. That's where I got my master's of public health at Harvard, focusing on healthcare policy and management, because I always wanted to focus on hospital-based care, making sure hospitals were better for people, all the time. And so now I spend my time when I'm not seeing patients doing this, coming directly into communities and giving talks, writing, talking on podcasts. So I'm getting this message out there so that you have tools to make your hospital stay better. So thank you for coming, and thank you for having me. So when I talk to people about hospitals, this is what they say. It was extremely scary when I was admitted, when my dad had a heart attack and we had to go there. You know, working with a bunch of doctors and nurses can be extremely intimidating, right? We ended up there and we didn't expect it. It was an unexpected thing. I was fearful. It's extremely expensive, right? You're gonna leave, unfortunately, with a large bill. I had some surgery. There was a lot of family drama. Hospitals are meant to be places of care and support, but too often they are experienced more as places of chaos, of fear, and of lack of planning. If it's done right, from both ends, people can say, you know, I went to the hospital and I got some answers, and that brought me some relief. I finally got that diagnosis that I wasn't really sure what was going on. I found the nurses to be very caring. And I have some hope that we can do things better. That's the message that you can have coming out of a hospital, but that requires preparation, participation, and advocacy. And that's what I want to teach you. Is any of this ringing any bells? Our nurse is like, yes. Yeah. So can you prepare for a hospital stay? When I think about the patients who end up hospitalized, there's usually two groups of patients. Patients who live in a world of chronic medical conditions. They either have a progressive or chronic illness or caring for somebody with a progressive or chronic illness, right? They are steeped in this world. They kind of understand what's going on. This isn't their first time in the hospital. And then there are people who never expected to show up, right? Even if you have a condition, you're doing well at home with your hypertension. Things are okay. You've never needed to be in the hospital, right? So what happens is you get an experience where one group of people have learned by trial by fire how to prepare. Another group of people are entering that trial by fire, unprepared. Why? Well, of all the things we talk about in healthcare, the last thing we talk about is being hospitalized. Nobody ever wants to think about going into the hospital or their loved one being hospitalized. The only group of people who go to the hospital willingly are pregnant patients, right? You pick out your doctor, you go take a tour, you look at the birthing suite, which is a very different experience than someone who's going to have the need for a cath suite, right? If you're having a heart attack, when was the last time you went and toured your local hospital to find out what does the hospital have? Can they care for stroke? Can they care for cancers, right? So we have this dearth of not just information, but the dearth of wanting that information because we just think hospitals are there. The hospital will be there if I need it, but I'll never need it. And the truth is there's so many different types of hospitals, right? We are very blessed. We live in the Boston area where we have not just South Shore Hospital, which is a regional medical center, which is a trauma center, which can care for strokes, which can care for heart attacks, which does deliver babies. But you also in Boston have a ton of tertiary care centers that can do really specialized things, transplants, right? Bone marrow transplants for cancers. These are not things that other communities have access to. So I always encourage people, take some time to find out what the hospital in your community is capable of, just for your own understanding and edification. Because if you call 911, they're going to take you to the closest hospital. Okay? And so I just always encourage people when, if you're buying a house, if you're moving to a new neighborhood, you're always looking at the coffee shop, you want to know what the school district is. Take a look at the hospitals as well and see if these are things that can support your needs and the needs of your loved one over time, right? Each hospital does things differently for lots of reasons. I don't think that people understand that every hospital can't have everything. It's way too expensive for every hospital to have everything. So if you're in an area that doesn't have something you need, you may have to be transferred. So just take some time and learn. That's the first step, is figuring out what's in your community, what do you have access to, and how does it play with what you need. The second thing I want you to do is really understand that as the patient, as the caregiver, you are the owner of information. That is your superpower in a hospital stay. That is your role. And in the hospital, information is safety. You're going to hear me say that a bunch of times. Information is safety. The more information I have about you, the more information I have about your loved one, the safer they are. And so as the holder of information, as the keeper of information, that is your superpower. And being prepared with that information is going to be key. So let's talk about the things I want you to prepare. The first thing that I want you to prepare is the medical legal framework for a hospital stay. Wow, big word. I know, I'm sorry. But it's really, really important. What does that mean? Medical legal, documents that are going to support you or your loved one in the hospital to serve as their voice in cases that they cannot speak for themselves, and identify people who can care for them and make decisions for them if they cannot make decisions for themselves, right? So what does that mean? The first thing is your healthcare proxy. Who is your healthcare proxy? Who is the person who you would trust to serve and make decisions for you if you cannot make decisions for yourself? Now, for a lot of people, that's their spouse, right? It may be a life partner or a sibling. A lot of times it's adult children. I always suggest that it be two people. Well, I should say the person have two traits. One, someone who is already your care partner, someone who already understands your healthcare journey, your needs, and maybe does a little bit of helping you to organize those things, right? Who goes to the doctor's appointments with you? Who already understands the things that are going on, right? And the second is somebody who you trust to take the direction from you, whether or not it's something they would do. So your proxy isn't someone who's going to make the best decision for you. It's supposed to be someone who will make the decision as you. So my favorite story was, I had a patient in the hospital, and she had a very loving older son with her, never left her bedside. But that person was not her healthcare proxy. In fact, her healthcare proxy was her youngest son, who didn't live in state. And so even though I had this gentleman who was with his mother at the bedside every day, I knew that if something happened, there was a guy somewhere in a different state that I would have to call for decisions. So I just asked her, out of curiosity, how come it's not this son? She said, well, I live with him. He loves me. He adores me. He would never, ever let me go. Now, my youngest, he and I don't get along, but he knows how to take directions. He knows how to follow what I say. And that's why she split it up, because she felt that if it came to a hard decision, she knew one son would be able to do something the other she thought maybe couldn't, right? So I always suggest to people that they have to have those two traits: someone who you trust to do what you would want done, and someone who kind of understands what's going on, so they have context. They're not kind of blindsided. The second thing is sit down and ask them. I know that sounds silly, but You would be surprised how many times I look at a paper and I say, oh, Deborah, you're your mother's healthcare proxy. And she goes, what? She never told me that. Sit down, have a conversation and ask them if they're comfortable with that, and then have a conversation so that they know what you want. Tell them this should be a lifelong conversation back and forth, that somebody knows how to honor you. And this isn't always about end of life, right? This is sometimes about making those in the middle decisions, right? And so sit down and talk to them. Is this something you can do, want to do? And here is how I feel. These are my wishes. These are my fears. These are my hopes. This is my experience, right? So that they are going into this empowered. The thing that I tell families is that these two things, your healthcare proxy and your advance directive, is your gift to your family. If your family has your voice and your wishes and your understanding of how you want to be treated, you are giving them the gift of direction and relieving them of fear and guilt and uncertainty. And oftentimes I see a lot of families really struggle with that when they don't know what to do. There's a lot of uncertainty, and people have a lot of emotions that can be very complicated and last a long time. So I say these are hard conversations, but I encourage them because that is your gift to your family. You're giving them the gift of clarity, which will relieve them of a lot of complicated feelings in the end. Now, in addition to the healthcare proxy, the person, there is a document, the advance directive, also called the living will. This is your document that you can write down everything so that I have your wishes in writing as well as your healthcare proxy, and we know that things are well supported. Now, I've seen advance directives as complicated as keep me intubated for 7 days. If I can't be extubated by day 7, right? And then I've seen ask Deborah, right? It's up to you what you want to write down. But I do suggest putting as much information as you can so that poor Deborah has something to look back on. And can feel supported. The second thing the third thing, that I want you to fill out is a MULST form. Does anybody know what a MULST form is? I have them here. The MULST form here in Massachusetts, we call it a MULST form. Other states might call it a PULSE form. It is a mobile order of life-sustaining treatments. This hot pink form is the only medical order you, as a patient, get to write. If you would like to write medical orders, it costs you 4 years of education, lots of tears and sweat to become a physician, but this order is yours. This is your order to write. And the reason it's hot pink is because we want it on the fridge so that if EMS comes into the home, they have it and they can follow your wishes from the beginning. And what does this talk about? This talks about things like CPR, intubation, which is the tube down the throat to put you on a machine to help breathe for you, other forms of supporting your breathing, resuscitation in general, and then on the back it has more specifics about IV fluids, coming back to the hospital, dialysis, things like this. The MULST form was born out of something called the PULSE form that started in Oregon, which was really about how do we support patients with complex medical needs to be consistent with their wishes and their voices, right? And what this document will do is it will live in the medical record, and we are able to now know when you come into the hospital, if you can't tell us what's going on, what your wishes are beforehand. Some people would say everybody needs a MULST form. I'm not in that camp, right? I say if you feel like this is something that you want to do right now, great, do it. But otherwise, sit down and think about it, talk to your primary care and see if this is something you want to fill out with them and get into the medical record. But if you are someone or caring for someone with complex medical needs who has found themselves bouncing in and out of the hospital, I do highly suggest that you complete this form. All right. And the great thing is it's paper, it's not stone. It can be changed at any time. You can get a new piece of information and update it, right? And so don't feel like just because you've written something or your loved one has written something today that this is gospel. This is how you are thinking about your care now. Things can change. But we want to be able to support you and give you the things you want when you come to the hospital, not the things you don't want, right? So when you come into the hospital, I'm going to ask you essentially all the things on the paper. I'm going to ask you, in the case of emergency, would you want to be resuscitated? What does resuscitation mean to you? Like things like that. So this is a good chance to think about it. It does need to be signed by an MD or an NP or a PA with you, and then put into the medical record. But it is a really great way, again, to support you, support your loved ones with their wishes when they go into the hospital. So that is the medical legal framework that I would like you to set up. Massachusetts is working on an electronic version so that we as a state will have more consistent access to it. We live in a great state for healthcare. Not every state participates in this form. And so it's definitely worthwhile. So that's the medical legal framework, meaning these are legal documents. This is also a legal document, right? Why do I know this? Because if somebody fills it out incorrectly, they call me to refill it all the time. And they remind me, this is a state legal document, right? But the reason I want this for you is I want you to be supported. And I want you to have your consistent voice and your consistent choices supported and acknowledged through a hospital stay. I also teach a course around this called Voice Your Choice, because for me, that's what it is. It's your voice and it's your choice. How do we respect that? Now, the other piece of information that you are the owner of, remember, information is what? Safety. Yeah. Information is safety. The other piece of information is your medical history and your medications and who is caring for you. You do not need to know every medicine, every dose, every special thing about it. You just need to know where I can get that information. And nowadays, it can be an app. Is it the CVS app? Is it your primary care doctor's app? There's also nothing wrong with a piece of paper. I've seen lots of people come in with it written on their wallet, like in a piece of paper in their wallet. This is great. Whatever the information is to tell me an accurate list of the medications you're taking, that is going to, again, really be important for your safety. Okay. Something that happened to me as a resident, and I will never forget this. I had a gentleman, we were caring for him. Day 4 of a hospital stay, everything was going great. Suddenly he has a seizure. And now we are scrambling. What happened? We're getting MRIs. We're getting neurology involved. A, B, C, X, Y, and Z. We're doing a bazillion-dollar workup. And a daughter who had not visited before came to visit, and we said, look, this is what happened. He had a seizure. We're going to do this. We're going to do that. She said, well, did you give him his seizure medicine? We said, excuse me? She's like, yeah, he takes seizure medicine. It wasn't on the medication list. This was before we had integration of all the different things. We said, well, we got the list from this pharmacy. Oh, but that's not the pharmacy he always gets his meds from. Dad, you didn't tell them that's not your regular pharmacy? Right? Information is safety. What medicines are you taking and how updated is it? And for those who are watching, oxygen is a medicine. If you or your loved one is using oxygen, let us know, because it makes a big difference to me and your safety if you come into the hospital and you don't need oxygen and suddenly you do, or if you come into the hospital and you're needing oxygen and there's a change versus not a change. So it does make a difference, right? Include your supplements, because supplements can interplay with medications, right? And include things that you're allergic to. Let us know. Information is safety. The next thing I want you to know is, or tell me, be able to give me the information, how to contact your primary care and or your specialized medical team. Do you have an organ in your body that wasn't originally yours? right? If you're a transplant patient, who gave you that transplant? That's important for us to know. Are you being treated for a cancer? It is important for me to know who your oncologist is. Do you have a cardiologist? Let me know who that person is. If you have a specialist who is treating you for something, I don't want to reinvent the wheel. I don't want my guys messing up what your guy is doing when it comes to specialty care. We want to have a consistent plan. So if you can get me information on how to contact these people, that is golden, right? Doesn't mean we're always going to be able to be in contact, but at least we have the information to start, okay? Especially if you are being treated for something highly specialized. That is really important for us to be able to be consistent with your treatment plan. Make sense? Questions? Is this a lot? Okay. Thank you. Now this is the fun part. I was the Associate Director for Hospital Medicine at South Shore Hospital for about 8 years. Still a hospitalist there, but have stepped down from that position to invest more time in my writing. But while I was the Associate Director, of the things that I did, one of the things I was called to do regularly was to resolve complaints. When people would have something they were upset about with the hospital medicine team, would land on my desk. What do you think the number one complaint was? It was communication. People didn't feel heard. People didn't feel like they were being spoken to on a regular basis. People felt like communication was extremely difficult, which led to a lot of frustration and sometimes poor outcome, right? If you've ever had a loved one in the hospital, you know that waiting for the doctor to call can sometimes take days, right? And there's lots of reasons for that. Are they great reasons? No. Have I fallen victim to them? Yes, right? And that's why I'm going to teach you how to drive communication in an effective manner, okay? So the first thing I want you to know is if you end up in the hospital, if your loved one ends up in the hospital, please don't go alone. If you can, avoid it. Hospitals are so complicated and so fast. It is extremely difficult to catch all of it. I'm going to give you 2 examples. I was a resident and I had to have surgery on my hand. So I have graduated medical school. I have been in residency. I signed up for surgery. I met the surgeon. I went there on my own. I'm in my 20s. My brain is all working. And I go and I have surgery. And my boyfriend, now husband, picks me up and we go back to my apartment. And a few hours later, he catches me in the bathroom taking off my dressings. "What are you doing?" he says. I said, "They said, take your dressing off in 7 hours. I've been counting down. It's 7 hours." "No, Monique, 7 days." He said, "Take the dressing off in 7 days." But I swear I heard 7 hours. I even counted down the hours, right? I got confused. I had anesthesia. I was in pain. There was a lot going on. Now, imagine that, and you're in an emergency department where you didn't sign up for. You didn't go there willingly. You didn't meet the doctor, right? If you had a meeting with the IRS, would you prepare for that meeting with the IRS? Yes, you get all your documents in order, right? So let's say you're going to your meeting with the IRS, and while you're there, you start getting a headache, you get a little bit of nausea. Would you still go to meet with the IRS? Probably not, but okay, let's say you're going, like, I felt worse in my life, right? I will go. But then someone rolls over your foot with a car, and then someone hits you in the head with a door, right? And you're bleeding from the nose, and your foot hurts, and you're nauseous, and you got a headache. Would you show up for the meeting with the IRS? No, because they're going to ask you a lot of really high stakes questions. But that's exactly how you show up in the hospital. And I'm going to ask you a lot of high stakes questions. You're nauseous, your head hurts, you're in pain, you're bleeding. And now I'm looking at you and I'm like, tell me all your medicines. What are you allergic to? Have you had a heart attack? Follow my finger. That is a lot, right? Those are just as high stakes questions as an IRS audit. But this is how you're forced to show up because that's the nature of it, which is why I always suggest to people, have a care partner. If you can, have someone with you to be an extra set of eyes, ears, an extra mouthpiece, an extra memory. You're going to forget a lot of things because you don't feel good. They'll remember what's going on, right? If you have somebody who can tag along, or if you can tag along for somebody, try not to be particularly in that emergency department alone. That is a high stakes situation, right? So if you can have a care partner, I really, really suggest people get one, find somebody to go with them. So now let's get into, and this is really cheesy, what I call my ear method for communication in the hospital. I'm going to teach you how to get the ear of your physician, okay? We're going to take the examples of Jane, right? So Jane is her mom's care partner, and mom is in the hospital. She's not feeling so good. She's in the emergency department. The first thing that Jane is going to do is she is going to set up communication expectations early. Day 1, not day 3, not day 5, when no one has called me and I'm upset. You set expectations early. Hi, I'm Jane. I am my mom's care partner. I am going to be with her today. I help take care of mom. She's not feeling so well. I am the person you need to speak with. Identify who needs to be communicated with. Early. Early. I am the person you need to speak with. Here is my number. Can I check that you have the right phone number? Whatever it is, to make sure that you have identified who needs to be contacted and how they need to be contacted early in the hospital stay. Day 1, sit down, wait. It's going to be long. I am sorry, but sit down and wait to meet the hospitalist, not the emergency department, the hospitalist, the person who is going to be caring for them on the floor, right? Or if you are the patient and you're not feeling so hot and you are by yourself, when the hospitalist comes, please contact Jane, my daughter. Make sure her number is in the medical record. That is going to be my contact person. So early, set up communication expectations early, right? The next thing I want you to do is tie every piece of communication to an action. I love hanging out with my patients. I have met really exciting and interesting people in the hospital. But the hospital is not a place for a social visit. Hospital is a place for us to discuss what we're doing to move your care forward, right? So I often tell my patients, if they're having a procedure, they're having a surgery, I say, I will see you after that, because otherwise it's a social visit, right, for the day. I want you to get your colonoscopy. I want you to get your CAT scan. I want you to meet the cardiologist. I want to talk to the cardiologist. And I will speak to you after that so that we have something to discuss and we can make a plan off of that. So I want you to tie every communication expectation to an action. Hi, I'm Jane. I'm the person who's going to be helping my mom. Please contact me. Here is my number. Early, and call me after the CAT scan, an action. Call me after you've spoken to the cardiology, an action. Why? Because you want that piece of information to drive care forward. I know people will call and say, tell me how mom's doing. I love it. That's great. But that's not the communication I'm trying to teach you. I'm trying to teach you effective communication to drive care forward, right? If you want to know how dad is doing, that is great. I would say ask the bedside nurse. She knows more, like the moment to moment. A little nauseous now, just got some medicine, went down to sleep. But when you're speaking to the physician, I want you to tie it to an action so that you are moving things forward. And are reasonable. Try to set reasonable expectations, things that can be achieved, because believe it or not, doctors love gold stars. We have gone through our whole education getting A's and gold stars, and we want a gold star from you. So if we can make you happy, that will make us happy. Setting up communication expectations that are realistic and achievable will help everybody to feel good and make sure communication stays smooth. What is not reasonable? Calling all 6 daughters, right? What ends up happening is, number one, there's a lot of phone calls to make, but 6 people will ask 6 different questions, get 6 different understandings, and nobody's on the same page, right? One person needs to be the point of contact for communication, right? And set that expectation reasonably once a day when conditions change around this action, right? Because if you're setting up expectations, and I'm going to give you an example of unreasonable, that are hard to achieve, you are going to feel let down, and then you are going to feel frustrated, and then the team, doesn't matter what the team does, is not going to feel like it's good enough, and the team is also going to feel like they're not good enough, and then it's going to become a problem. So I once cared for a woman who wanted the nurse to call her every time she gave her mother a medication. You see your face. How reasonable is that? No. Right? Why is that unreasonable? Well, medication pass is a high safety issue for nurses. They want to make sure they have the right medicine to the right person at the right time in the right way. Interrupting that process for a phone call will take away from the safety. The other thing is, it can be several times a day you're in and out of the room, right? And so she was saying, well, the nurse doesn't call me. And we went back and forth. And what I ended up figuring out was she had a lot of fear because her mother once had an adverse reaction to medicine. So I offloaded the communication. And I said, okay, when we speak, I will go over the list of medicines for the day with you. So she got one touch point, right? That's how we resolve that, right? That takes a little bit of investment from both parties, but we were able to resolve that, right? But if you are setting up expectations or you have internalized expectations around communication, like I had a gentleman who came to one of these events and he said, if I didn't sit at my mother's room from 8 a.m. to 5 p.m., I would never get a phone call from the physical therapist, from the speech therapist. I would never X, Y, and Z. In all my 20 years, I have never met a physical therapist who calls families after every visit in the hospital. Wound care, it was the same thing. He was upset about wound care. The wound care nurse will come by, do wound care, and then talk to the nurse, and they have this professional conversation and orders are placed, but he wanted to speak with the wound care nurse. If that is what you need, then you need to make yourself present, like he did. He didn't like my answer, but if that's the thing he needed to participate in the communication that way. If you want to know what physical therapy said, tie it to your communication with me. Dr. Nugent, I want to, after you get that CAT scan and physical therapy has seen my mom, give me a call. After I see the physical therapist today and the speech therapist, I want to talk about our plan. Right? You have to tie it to an action. It has to be reasonable. If you can do that, if you can set expectations for communication early, tie them to an action and keep them reasonable, you can get, I told you I'm very cheesy, the ear of your doctor in the hospital, and you can make communication better. It will take time to learn the skill, and not everybody is going to have great results immediately, but it is something that will pay off over time. If there are more people who need to be pulled into the conversation, if there are 6 daughters who need a phone call, that is a time for a family meeting. That is a time to get everybody together at one place so that you're all hearing the same message, you're all asking questions in front of each other, and the communication is all together. Family meetings for me are actually my favorite thing for communication in hospital stays. Again, because no person is like by themselves, or no person is an island, right? That's the saying. And no decisions made in a vacuum, right? So even caregivers, even healthcare proxies have someone who's supporting them to help make decisions. And sometimes there's lots of stakeholders. Let's get everyone in the room together and we can have a great conversation. The next thing, and the most important person, and she was actually alluding to it, is discharge planning, is your case manager. Case managers, to me, are the superheroes of the hospital. They are nurses who focus on what you have access to in your community through your insurance to help get you out of the hospital in the safest and most effective manner to continue your care. And the reason I call them the superheroes of the hospital is because they live in this bridge between the medicals and the social needs, right? And so I can tell you, I have made a lot of really great, what I thought, wonderful, groundbreaking medical plans. The case managers will come back at me and say, yeah, Monique, I'm sorry, they don't have access to that. No one can do that in their area. They can't get, that medication delivered out there. So we have to rethink it. Your case manager is going to be the person that I want you to really focus on sharing all of the things you need to be able to leave the hospital in a safe manner. And if going home isn't safe, then where is the next place and how can we get there in a way that we can support? Because it can be very complicated to get people out of the hospital. Which goes into clarifying the discharge plan and where am I going next. Discharge planning starts at admission. I know, give me that look. I was waiting for someone to give me that look. Nobody likes when I say that. It doesn't mean that when you come into the hospital, I'm planning on how I'm going to boot you out. No, what it means is that I need to understand what you were able to do, what your supports are, how you lived before you came into the hospital, so I can plan to return you to that, right? So when I was a younger doc, I would get very upset at what we call social admissions. People who would come into the hospital because they couldn't be safe at home. They couldn't be cared for. Family was no longer able to keep them safe, or they themselves weren't able to care for themselves. And I wanted to see heart attacks, and I wanted to be like the Pit, right? I wanted to do all the cool medicine stuff. In my old age, I have come to understand how important the hospital is in making sure that you are safe. And safety means a lot of different things. And sometimes when people come into the hospital, planning for them to be safe can be a lot more complicated out of the hospital than we realize. And I have come to see those type of admissions very differently. In fact, I encourage people, I will say, if you can't care for your loved one at home, you might need to bring them to the hospital so you can get resources and you can get a plan, because the last thing you want is someone to be unsafe at home and get hurt, right? And so thinking about what you have at home and what home means and what home will look like after your discharge is really, really important, which is why I say planning for discharge starts on admission. And that comes down to the question is, where am I going next? If home is the place you're going, that's great, but what do you need to be at home? Is it something as simple as antibiotics delivered by CVS? Wonderful. Or is it a new walker? Is it a higher toilet seat? What do you need to be at home? And if you can't go home, then speaking with your case manager and finding a place that is going to help you get stronger and safer to return home, if possible, is going to be key. Hospitals rarely make things better. They just make things different, right? So even the people who are excited to come to the hospital, right? The pregnant patients who sign up and wait for 9 months in anticipation of that hospital stay, they leave with life different, right? So I would say it's the rare 27-year-old with a toenail infection that comes into the hospital and leaves and everything is fine, right? Leaving the hospital means that things will look different. They may not look different forever, but they will look different in the interim until you continue your care. Getting better doesn't happen in the hospital. Getting better happens out of the hospital. The hospital is a place where you get diagnosis, you get treatment, you get stabilized so you can continue your care. And this is why I say Hospitals rarely make things better, they just make things different. And I want you to think about what different looks like. Your medications and equipment. Will you need new medicines? Do you need refills of the medicines you currently have? We can do that for you at the hospital, right? How will you get your medications? If you're signed up for delivery, can you really get the antibiotics from delivery, or do you actually have to pick the antibiotics up from CVS, right? How are you getting your medications in a timely fashion to support you? And what medications can you take and not take when you leave? You may not be able to continue taking some that you were taking before you got into the hospital. What does your medication list look like? Medications and equipment safety is extremely vital to keep you out of the hospital once you are discharged. Extremely, extremely vital. So when you're leaving with your loved one, or you're leaving by yourself, really take a good hard look at that medication list that you're leaving with at the hospital, and make sure when you go home, I tell people, have 3 piles. The keep pile, so this is what I have to take, this is new for me to take, and this is what I can't take anymore. And make everything into the appropriate piles so that you're safe and you know what you're taking, and you avoid another hospitalization because of a medication issue, which happens a lot, which includes ensuring you have access to the medication before you leave the hospital. Some medicines are very expensive. There's lots of paperwork to fill out with your insurance. The last thing I want is for you to leave and then get to CVS and figure out like, oh, I can't actually get this medicine because my insurance doesn't cover it. And then you have a different problem, right? So working with your case manager, there we go, superpower. They know what you have access to when you leave the hospital. Equipment, and the reason I put equipment with medications is because I consider that to be a prescription for safety. If your physical therapist says you need a cane, it doesn't matter if you don't like it, jazz it up, bedazzle it, do what you have to do. But that is for your safety. And the last thing you want to do is get injured. My grandmother, she bought 2 new hips up in Toronto. The way she did it was from furniture walking. I would go and she would like walk the furniture like this. And she had this thing she did with the refrigerator where she would hold onto the door and then like swing it open and then catch the counter. And that's how you get 2 new hips in Toronto. Okay? Like, the last thing you want is to be unsafe in your home. Falls, injuries will get you readmitted. So I consider the equipment to be a prescription, right? Just like I consider dietary changes to be a prescription, but I just had a podcast episode with a dietitian who counseled me against that. He said, these are therapeutic diets, Monique. That sounds nicer, so I'm going to use that phrase, right? But please, please use your equipment. Appointments. If you are my patient in the hospital, you have had homework. And that homework was the day before I'm discharging you, I say start calling and making your appointments. So when I see you tomorrow for discharge, you tell me that you already have these appointments. Why? Because appointments can be really hard to get. So I always encourage people, if you can start making appointments while you're hospitalized, you are not losing anything. It is easier to cancel something you don't need than to get something that you really need but you can't get, right? So make your PCP appointments before you leave the hospital. Please don't wait until after you leave the hospital. What will happen is something will happen. You'll call the hospital and say, oh, Dr. Nugent was my doctor. And they'll say, oh, she only sees hospitalized patients, which happens, right? So get that appointment. Neurology, I heard neurology on the South Shore is currently at 6 months wait, right? So if you need specialists, make sure that you have those appointments. Make sure if your insurance says you need to go through your primary care, you go through your primary care to get your referral. My referral may mean nothing to your insurance agency. It all depends. Your case manager, again, superpower, they can help you to understand that, right? But get those appointments. And then with therapeutic diets, this is a place where I say give yourself space and grace. Learning to eat differently takes a lot of time, right? If the doctor suddenly says you can only drink 1 liter of water, my goodness, that is extremely limiting. Give yourself space and grace on how to get used to that. If you can work with dietitians, if you can work with the visiting nurses when they come, you can do that. But at least try and start the process of figuring out how to eat the way that will keep you out of the hospital, right? Is it low sodium? Is it low potassium, right? If you are someone who needs dialysis, right? There are really specific diets. And so if you've had dietary changes in the hospital, if your loved one has had dietary changes, please do your best, but also don't beat yourself up to think, oh, I had one thing of popcorn and now, I'm the worst. No, give yourself space and grace to learn that. The other thing that changes with diets in the hospital are textures. People may not be able to swallow things the way they were swallowing before they came into the hospital. And so if your loved one leaves and they need like a puree diet, a chopped diet, thickened liquids, learning how to cook like that, learning how to incorporate that into the home and into your family takes some time. But doing that is going to maintain safety, and that is really important. So this is where I do encourage people, try your best, realize it's a process, you will get it, keep trying it again and again to learn the dietary changes that come after a hospital stay. In the hospital, when something bad happens, we do something called a debrief. Some other places might call it stop the line. So a patient falls out of bed. After the crisis is over, after we've picked them up, we make sure nothing's broken. We sit down as a team and we say, what happened? How did we get here, right? Was the camera turned off? Was the bed too high? How did we respond? Did we respond fast enough? And what can we do to improve? I suggest taking that thought process with you home after a hospital stay. Not the day after your discharge, but sometime later when the dust has settled. When I do counsel families privately, I always suggest that you do a debrief after a hospital stay. Say, how did we get here? Wow, did Dad really just have a heart attack in the middle of Stop and Shop? How did that happen? Was this something unexpected, or was this something that, was something that we hadn't really managed, we weren't really aware of, right? How did we get here, right? How did we respond as a family? Were we able to come together? Did we have the medical legal framework? Did we have a MOLST form? Did we have who's the healthcare proxy? Did we have all this information? Were we able to be supportive, right? And what does this mean for us? What changes? What financial changes have occurred because of this hospital stay, right? Hospital stays come with a lot of financial changes. It may be that you meet your out-of-pocket costs, right? So when my first daughter was born, she was a preemie. And by the time we left, we had met our out-of-pocket costs. So when she needed a procedure, we knew it was covered, but we had that financial discussion as a family, right? Are there changes in medication coverage? Are there changes in days of access to skilled nursing facility? What financial changes have occurred and do we need to think about since this hospital stay? What documents need to be updated, right? Do we need to update the MOLST form because we've had a change in diagnosis? Is the healthcare proxy still valid? You really have to think about that one. I had a very unfortunate case not too long ago where the healthcare proxy died during the hospital stay, right? So now this person with dementia had nobody supporting them. Documents had to be updated. Why? Because hospital stays make things different. So I always suggest that you sit down, again, after the dust has settled, maybe a week or so, and say, do my healthcare goals still stand true? Are we up to date on what this means for us financially and this new world that we're living in after discharge? Are all my documents in play, or do I really need to update the advance directive and the MOLST because of what has occurred in the hospital? And what are my social supports? Do I need a little bit more support in the home? Do we need a housekeeper, a personal care attendant? Do we need Meals on Wheels? Do we need more supports around, or are we okay? And that's fine to say we're okay. I've met a ton of families who are very supportive and do very well by themselves. But I want you to check in on that. Check in on that social supports to make sure you have everything you need. So this is actually a newer process that I have started teaching and counseling people on, because I really think that it will help people to be more prepared if they need to be hospitalized, but also more prepared to continue moving forward with care after a hospital stay. And it's, like I said, it's a process that I kind of stole from hospitals, and I'm teaching you in your home. This book was first an idea I came up with during COVID to teach people how to be hospitalized during COVID, but you will not find the word COVID in this book, because this is really a guidebook to any hospital stay. This is written for patients and caregivers. I break down a hospitalization into what you can expect each of the 4 days. I've got pages for you to fill out your medical records. I practice filling out your MOLS form and things like that, so that you know exactly what you're getting into. Somebody once asked me, a publisher asked me if I would ever offer hard copies, and the answer is no, because I want this rolled up in a bag. I want the dog-eared pages. I want it written in. I want notes, because this is your guide to a successful hospitalization. Also, you can find me, like I said, I've got a podcast, because I lack imagination. I just named it after the book. So it's very easy. Look for the Prescription for Admission podcast, where I talk about a lot of these same things. I have 2 episodes a week. One is like a 10-minute quick tip. Another one is a little bit more in depth. But I really want you to have this information. The reason I make this information available is because, and I'll end on a little bit of a joke, but because I've come to understand that the hospital is a DMV. Well, I'm from New York, so the DMV, the RMV of healthcare, okay? Everyone's gonna show up there at some point. No one's gonna be happy about it. You might have to go back. You'll feel like you got the runaround, right? So what I want is to hopefully make that experience better for you. Thank you guys so much for joining me. I know this was a lot, but this is what I love doing. I love talking to groups about all of this.